Hi everyone, this is Beth Newhoffen from Denver Health in Colorado. We are a safety net, a large academic medical center, and I primarily work with specialty care, but I work with the hospital ED and primary care as well in the medical neighborhood. And I will give you a couple examples, but I want to start quickly with just engagement from practices and how you nudge them. Maybe you're in a position where you'd like to start something like this, and you haven't had those conversations. So what I do is I usually ask the providers when I'm sitting with them and ask them what their view on healthcare waste is, dollars, utilization. I ask them what they personally think they could do better, or as their team in regards to cost utilization services. I'll give them some examples. And then I'll often send them ideas, maybe papers, articles, just to kind of pique their interest, to kind of nudge them like, oh, if you're hearing from me, this is what I'm thinking. And definitely, I always give data. You know, it's hard to have a conversation if you don't have data around ED, avoidable ED visits, or your readmissions, or your duplicate lab tests, or whatever you want to do around utilization. It is very helpful to have data. And then I'll often just encourage healthy competition amongst the providers. It works really well. I'll give them examples of what their peers are doing. And once we've had a successful clinic, I'll get them in front of leadership. I'll get them in a newsletter I write. I'll get them out there so that their peers and other specialty practices see what they're doing. And then they want to often join in. And I'll give you an example of that here. So one of the ways I started with the ENT clinic that Carol referenced was actually not through a conversation of utilization, but through team-based care. The nurse in the ENT clinic was fairly dissatisfied with her job as a nurse and being on the phone all the time. And she wasn't happy with her engagement with patients as a nurse. That's why she got into nursing. So after doing a series of team-based care meetings that I had with all the specialty practices, we were able to do roles and responsibilities. And what she had been doing prior to that was a lot of computer work, and she was triaging referrals and things that are important, but she wasn't having that patient engagement that she wanted. And so we actually took the triaging that the nurse did and we put it to a physician's assistant, and that enabled the nurse then to start doing these post-op calls for their patients. And so the nurse would go over things like discharge instructions or errors, medications, red flag warnings, any kind of errors as far as patient understanding. And she would go over that, spend some time with in that clinical sense with the patient 1 to 3 days after their discharge from outpatient surgery or from the inpatient. And what happened from that was not only did the avoidable ED visits decrease tremendously, but also the show rates for those post-op appointments went to 100% show rate. And before that, it was about 75% show rate. And so that, of course, increased our access to care. The patients were happier, the nurse was happy again, and of course the providers were happy around that. And so because of that, a lot of practices, specialty practices at Denver Health wanted to get on board. So now there's multiple practices, orthopedics, urology, surgery, wanting to do post-op calls. Women's care is wanting to do duplicate lab tests. There's an opioid program going on. That light lit the fire for everyone else to want to get involved, and also for wanting to do healthy competition of who can be the best. And we also do I do the medical neighborhood here at Denver Health, talking about same-day urgent spots we have. We do what's called e-consults, where primary care providers or referring providers can have a e-consult with a specialty care provider, and oftentimes the patient doesn't even need to be a part of that or come in. The primary care provider then can manage that condition, or then it can be flipped to a official referral for the specialist to see the patient. But oftentimes that opens up access for patients in a more immediate sense. We do pre-consultation exchanges between providers where they can just call each other and have a conversation to help the patient more emergently. Like Carol mentioned, we also do flyers. So when a referral is put in, the patient is given a flyer for that specialty when they're given the referral. They know all about them. They know the hours, what to expect, what to bring, what are the days, who should they call after hours. They already have an engagement tool that they could have beforehand. They talk about the goals of the visit, and the triaging is done with in mind the clinical referral guidelines appropriate for the patient, so that first visit is really of high value and patients feel like, oh, I can talk to my providers are on the same team, I don't have to go to the ED, I can reach out, everyone's on my team. And so those are just a couple of